And thank you everybody for coming to participate in this webinar today. Again, as Alex said, this is educational. At the end, on the final slide, I will provide contact information, and I always welcome follow-up questions or concerns, anything that you'd like to further talk about. We'll have that contact information at the end. First, let me give some disclosures. Insightech is the sole manufacturer of the hardware and setup that is used for focused ultrasound techniques, which we'll be talking about today. I have no financial relationship with them, but some of the slides that I'm using today are theirs in modified form. All right, so let's start off by talking about what we're going to consider today. First is, when do we decide that we've run out of room to use medications for control of tremor? What are the options? And I apologize for the break in the word there, but what are the options if medication is not enough? What is available in terms of surgery, and what does surgery mean? We'll talk a bit more in detail about focused ultrasound, which is the newest option, not new as in this year, but approved by the FDA about 9 years ago now. And then a little bit about how people are evaluated to see if they are good candidates for treatment like this. So, as I've already implied, medication is the primary treatment for all types of tremor. And we're going to talk mainly about two types of tremor today, something called essential tremor, also sometimes known as familial tremor, and also about tremor that occurs in the context of Parkinson's disease. These are two different types of tremor that occur in different situations, but interestingly, they can both be treated very effectively by very similar types of surgery. So we'll go into that in a little bit more detail. In any type of tremor, and in most symptoms in medicine, if you can control the problem with medication, with a pill, that's what you do. You don't turn to surgery unless the pills are not working. And what does that mean? Well, it means that you take the medication and it doesn't solve the problem. It doesn't suppress the symptoms. Or it does help, but only at doses where you get side effects that are a problem, or sometimes worse than the disease, or the cure is worse than the disease. The type of medication that's used for essential tremor or Parkinson's, those are different. Those are very specialized areas that are kind of in the province of neurologists. I work very closely with the neurologists. We have an integrated team that deals with our patients together and makes decisions together, and that includes neurologists, me as a surgeon, neuropsychologists, radiologists, whole group. My particular expertise and what I'm going to be talking about today is the types of surgery that are available when medication doesn't work. But I will tell you that the medications that are used for essential tremor and for Parkinson's are very different. Those are evolving areas. We can come back to that a little bit at the end. But part of what we do during evaluation is we want to be certain when someone comes to us that the medication options have in fact all been tried before we do things like surgery that are basically irreversible treatments. Okay. What is essential tremor? This is the most common movement disorder. Depending on what you consider to be tremor, something as high as 40% of the adult population over the age of 40 in the United States has tremor like this to some degree. It is mainly a postural tremor. It's rare that it occurs at rest. Mostly this is a tremor that happens when trying to hold your limbs, usually the hands is what we're talking about, trying to hold still in space. It can also be an action tremor, meaning that it occurs when you're taking an action. So for example, holding your hand out to hold a tray still, or picking up a cup and bringing it to your lips. It occurs mostly in those situations. And there's probably more than one subtype of essential tremor. Some of these are inherited at an early age. Some of them are inherited later in life, some of them not at all. So it's probably more than one problem. The standard medications for tremor of this type, essential tremor, familial tremor, are propranolol, which is a beta blocker that's also used for blood pressure and other indications. and primidone, which is a barbiturate, a sedative. These are the standard medications that have been used forever for this. There are a few others these days that are much less commonly used. When those two, propranolol and primidone, don't work is when we begin to think about maybe medication is not going to be enough. The tremor in Parkinson's disease is a resting tremor, not one that happens when you're trying to hold still, but one that happens when the hands are at rest on the table or in your lap. But it's not the only symptom of Parkinson's disease. It can be the most prominent one, in which case we refer to that as tremor-dominant Parkinson's disease. But Parkinson's also has other symptoms which you see listed here, and different symptoms occur to different degrees in different people. So there are people who have much more of a tremor issue with Parkinson's. There are people who have very little tremor and mostly have problems with stiffness or with balance and so forth. One of the things we do in evaluating people as candidates when medicine isn't working is we try to decide which of these is their dominant form and how much of the separate problems here are interfering with quality of life, and we proceed according to that. Interestingly, although it's a tremor that occurs in a different phase of activity, it's a rest tremor rather than an action or postural tremor, and even though the medications that we use are different, the surgeries that we use are very similar. There's something about tremor that has a final common pathway that works in kind of the same way for both of these things. And the idea of using surgery to correct problems like this is not a new idea. This goes back to the 1940s, 1950s with discoveries that were made during some of the surgeries done back then. In the days before we had good medications for these problems, surgery actually came before medicine in many ways. For example, in people with Parkinson's disease that had very severe tremor, the gold standard medication for that didn't get FDA approval and come onto the market until around 1970. Before that, surgery was the mainstay when the symptoms were out of control. And the early days of surgery actually involved intentionally paralyzing people on one side to stop the tremor because it was so distressing. And it was in the course of operations like that that discoveries were made about less invasive ways to stop the tremor by making surgical changes to very small, precise areas in the brain. And so as we accumulated more knowledge of the anatomy and mechanism of how these tremors work, we got more and better refined methods for using both medicine and surgery to get control of these things. And that's what I mean here when I say that functional neurosurgery, meaning surgery to alter the function of the body, goes back even before medications. Just very basically, you can think of tremor as a problem in a fine-tuning circuit. The body would like to keep the hand in a certain position, either at rest or held out or taking an action. And your brain is constantly getting feedback on where your hand is in space, and it's adjusting the muscles accordingly. So if the hand begins to fall, your brain tells you to pull the hand back. If you pull back too much, the brain says, no, that's too much, go back down again. If you're trying to fine-tune those movements, but you have the gain turned up too high, then what happens is you overcorrect. And that's essentially what tremor is. It's this fine-tuning circuit trying to make the movements more precise, but it's set too high. And so instead of holding a position, you oscillate. You go up and down around the position you want. And that's the sort of a oversimplified view of what tremor really is. The surgeries for this, and to some extent the medicines, they don't really correct the function of that circuit. They don't make it work the way it's supposed to. They basically eliminate the circuit, either with the medicine or with the surgery. In the case of surgery, which we're going to talk about today, you actually do something to interrupt that circuit, just basically to shut it off so that it's not doing that anymore. Your brain has other ways of holding position. That's not the only one. It's one of many circuits. And if that circuit is doing more harm than good, you're better off with it not functioning. And then over time, if that's shut off, the body has very good mechanisms for letting those other control systems come online and help refine the position. So that's the basic principle. Taking a malfunctioning circuit that's, just like I said, it's fine-tuning, that's gain turned up too high, it's making the problem worse instead of better, and you just shut it off. The old way of doing this in the past was that we would actually locate that spot in the brain. We would do open neurosurgery through a little burr hole in the skull, incision in the skull, little drill hole, and we would put in a very fine electrode, a wire, down to the target area in the brain where this circuit was malfunctioning, and then we would heat up the tip of that wire. We would actually physically burn a little hole at that point. Before we burn the hole, we would run a little bit of electrical current through that wire to see what it did to the tremor. When we were in the right spot, the tremor would stop. That told us we were in the right place. But you can see that this wasn't the ideal way to do this for a couple of reasons. First of all, we could not directly see where the tip of that electrode was. We were taking our best measurement from landmarks on the outside of the head, but you couldn't actually see where it was in the brain. There's a little bit of imprecision in exactly how high you turn the temperature up. And of course, you never wanted to burn big holes in the brain. You wanted to make them small and precise. So there were possible complications in doing things that way. The biggest one was we tended to make those holes too small, and so the tremor would come back. So there was a high recurrence rate. There could be problems, of course, if the hole was too big. But the main dissatisfaction was that you sometimes had the tremor come back, number one. And number two, when you did that, mostly for essential tremor, but for Parkinson's also to an extent, you could only treat one side. You could not burn holes like that on both sides of the brain because it interfered with speech. People could not talk properly after that. And when you think about it, it kind of makes sense, because I just talked about how this surgery involves interrupting a fine tuning circuit. Well, muscle control of the vocal cords is something that requires very fine movement. So that fine tuning circuit gets involved there. And if you interrupt it, people would have trouble speaking. If you had one side working, you were okay, but we were limited to treating only one side. So there was interest in treating such a common problem, so many people having difficulties in quality of life with tremors. Medications didn't always work it, but the surgery that we had at the time was not super in a number of ways. It had some drawbacks. Well, that idea came back again, and I'll talk a little bit later about the electrical stimulation and how that fits into another treatment you may have heard of called deep brain stimulation, or DBS. But that old idea that you could find a spot in the brain that was involved in this control of the tremor, interrupt it, and make the symptoms better never really went away. So the concept came back around the first part of the 21st century, and ultimately in 2016 got FDA approval for doing the same thing in principle, making a little hole in that spot in the brain, but now doing it non-invasively, doing it with sound waves from outside the brain. So no cut in the skin, no drill hole, no wires going in there. Furthermore, not only could you do it non-invasively, but you could do it in an MRI scanner, a modern MRI scanner, which could actually show us during a procedure like this exactly where our hole is appearing and exactly what temperature we're raising the area to. So much more precise control, allowing us to be more effective and safer in doing this. So let me talk a little bit more about how that works. And first, everybody, of course, is here because they want to know, well, what does this actually do? What do we expect in terms of results? Here's an example of some of our recent patients. What you're looking at on the left is what their motor control, their handwriting, spirals and straight lines and signing their names. That's what it looked like at the beginning of the procedure. And an hour later, when the procedure is done, that's what it looks like on the right. So there's the same person on the top and the same person on the bottom. That's the effect that we want to see from this. And it is just as dramatic as it looks there. This is a great procedure, and you can see some of the results there yourself. Here's yet another one. This is another patient where you can see the same thing on the top. That's the beginning and the end of surgery. This nice lady gave me permission to use these images. On the lower left there, you see on an MRI scan done afterwards, this is the little spot that we make with the sound waves. That's where we're focusing things. That's what gives us this effect. And a very nice letter that she wrote to me afterwards, because she told me this was the first time she'd been able to write Christmas cards to her grandchildren, and the sort of things that make me passionate about doing this kind of surgery for people. So obviously, we can get some very effective outcomes in a much safer manner than we had available in former times, but the principle has been there for a long time. So this is very well understood, and the safety margins very well understood. Let's talk a little bit more about how this all works. So I've mentioned a little bit already about what essential tremor is. It's called essential. This reminds me to why is it called essential? It's not because it's essential to you and you need it. This means that it's part of your essence, that we don't know why people have this, exactly what causes one person to have it and another not. As you see there, it's often called familial tremor because it can be hereditary. This is a slide from Insightec, and I've asked them, why are these two people in the hospital? They don't really know either, except this apparently is a mother and daughter, and they're both comparing their tremors. This is probably part of a workup. But as many of you in the audience may know, these tremors can be very severe to the point of people having trouble writing their names, having trouble buttoning buttons, feeding themselves. I have patients who can't actually put their hand on the table because of the severity of the tremor. But I also have people whose tremor is much more subtle than that, and yet is a significant factor in their quality of life. So I had a patient once who was a highway patrolman who found it very humiliating to write out tickets because of his relatively mild tremor, but it was obvious when he was doing this or when he was testifying in court. I had someone who was a product demonstrator at Costco, where you can see that you don't have to have a high amplitude, very obvious tremor for this thing to become a significant factor in quality of life. So we work with our patients to decide, when have we tried enough medication? When has this risen to a level where surgery is a consideration? And we have people with very severe tremors who just aren't really interested in surgery, and people with milder tremors who are. So, we have flexibility with that, and we work with what patient expectations are and try to achieve those outcomes. And here, this is familiar to a lot of people in the audience. This is a demonstration of this postural and action tremor. Okay. And again, a high percentage of people that don't get complete control of medication, or that get control only at levels that cause side effects. So there's a need for this kind of treatment when the medication doesn't do its job. Here's just a few numbers, estimates of how many people out there actually have, for the United States, how many people have essential tremor. That first number, the 7.4 million, again, as I mentioned earlier, kind of depends on how you define tremor. It may be actually higher than that. A lot of people don't really go to the doctor and get a formal diagnosis of what this is. About 1.5 million people who have this diagnosis on their medical charts and call it essential tremor, about half of them find that the medication doesn't do the job. And of those, when you go through all the processing, maybe half of those are good candidates for a surgery like focused ultrasound. But very few of these people who are candidates for this actually end up having it done. There's a huge amount of undertreatment and of lack of understanding of who's a candidate for this, what's involved. And so there's a real need out there for, I think, for education like this to let people know what's available. These are not emergencies. This is, thank God, we're not talking about aneurysms and cancer. These are quality of life issues. But I think it's important for people to understand what is available to improve quality of life. And in all the years that this has been around, and I've mentioned that the history of this goes back decades, we just haven't done so well in terms of getting the idea out there that things can be done and that procedures like we're talking about today are available to help with this. So 97% of people who might be eligible for things like this go untreated. Now, there's different things that can be done for tremor. I apologize for that middle slide where it's kind of hard to see what that's about. We've talked about medication. We've talked about surgery. In between, there are things like weighted gloves and other mechanisms that have been devised to help with tremor. Not so popular in my experience. People don't want to go around and wear weighted gloves to do things. It's sort of trading off of one problem for another. Most people, if they don't do well with medication, when they come to me, they're coming to see a surgeon, so they've already thought about this. But very few people would consider wearing a weighted glove for the rest of your life to damp out the tremor to be a good way of managing the problem. Focused ultrasound, as I mentioned, has now had approval for the last 9 years, FDA approved in 2016. The history of development of this technology goes back farther than that. This is not new stuff. This is now second, third generation hardware and software, rapidly growing experience. And I'll come back to that again a little bit later in terms of how many of these are actually done. This, again, some slides from Insight Tech showing some of the advantages. This is done with sound waves. Sound waves are not radiation, so there's no cancer risk from this the way there is. Similar things have been done in the past with radiation, with gamma rays and so on that focused on these targets in the brain. We can get into that if people have questions about it. But the advantage of a system like this using ultrasound is that there is no radiation involved at any stage of this. And here's a little bit of an animation of how this works. It's done, as I mentioned before, in an MRI scanner. There's a frame on the head. Obviously, we don't want people to be moving their heads around while we're aiming these sound waves at the point that we want. We do some planning with the MRI images to choose the target. And then it doesn't actually look like that, but those are kind of to give you an idea of what's happening with the sound waves. Our patients are awake during this procedure because we want to see what we're doing. This is one of the advantages here. We can test as we gradually turn up the amplitude on the sound waves. We go in there and see, are we getting a benefit? Are we having any side effects? So all of those things add to the effectiveness and safety of this procedure. In general, the whole thing takes about an hour, hour and a half. Each blast of the sound waves there, it lasts a matter of seconds, something between 12 and 20 seconds for most people. People do feel something when that's happening, but it's very, very brief. It's usually a sensation of movement that people have, but it's very well tolerated. Nobody likes to have their head in an MRI scanner for a long time. And in my experience, people who have concerns about that usually are pleasantly surprised that the experience is really one of going in and out of the MRI scanner. It's not one of these 45 minutes in the scanner kinds of things. So in general, it's really very well tolerated. And this is, again, a demonstration of what I've kind of shown you before about the before and after. Again, we're using focused ultrasound, meaning we're taking those high energy sound waves and focusing them. Here it says the lesion's about the size of a pea. I would say it's maybe a little bit smaller than that. This is technical information about the part of the brain that we're aiming at. We'll come back to this stuff about DBS and so on. But basically, these names, VIM and so on, this is the circuit that I was talking about. This is the fine-tuning circuit that's turned up too high. We've known for many decades where that is in the brain. We can spot that on the MRI scan with respect to landmarks that we recognize in everybody's brain. And so we can go right to the point that we want and gradually turn up the energy of the sound waves, watch the tremor go away, and then try and make that a permanent fix. So who would be a candidate for focused ultrasound? Well, obviously, we want to make sure that we have the right diagnosis. The key to success in any form of surgery is matching the right patient, right diagnosis to the right treatment, and also, not really pointed out here, having realistic expectations of what this is going to do. It is a technique that's designed to take a problem that is not controlled with medication and to bring it under control. When we can get 100% permanent tremor control and get people off medication, of course, that's ideal. But safety always comes first. And so the goal is to take an uncontrolled situation that damages quality of life and reduce it to the point where it is no longer a problem. So not everybody gets 100% all gone tremor. Some people need to stay on a little bit of medication. We aim for perfection. We get close, and I'll show you some of those numbers. We rarely see people who are not improved by this, but it is very important for people to understand what the goal is, and to have tried medication first, to show that medication's not enough, to have a confirmed diagnosis, and to have realistic goals. So a few of the other things here for essential tremor and Parkinson's, there are certain lower age restrictions for this. You cannot be sedated during the procedure. In most people, sedation will make the tremor go away. And then, of course, when we go in there and turn the dial up, we can't see whether we're having an effect if there's no symptom there. But again, we're talking to people through the whole procedure, going in and out of the MRI scanner. There is a panic button that the patient has that they can turn the whole thing off if they don't like what's happening. If you hit that button, that doesn't stop things for the whole day. You can start up again. But we try to make this as easy and as comfortable as possible during the procedure. And this one, of course, can fit in the MRI scanner. Not only fit in the MRI scanner, you have to be able to fit in the frame. The frame from Insightec is one size fits all. It has different size attachment points. We have had occasional patients where they are too large to fit in the frame. So one of the things I like to do in clinic in advance is to make sure that it's actually going to fit on people. There is an opposite too. There are people whose head is small enough that it's difficult to get all those sound waves to go in. So there are certain restrictions here. Also, the sound waves have to be able to get from that helmet to the target in the brain. That means that they have to go through the skull. And the bone has to have certain characteristics. It has to be dense enough. The great majority of people are okay with this, but we always check in advance to make sure that you don't have a calcium deficiency or that the bone density will allow the sound waves to go through. Again, very, very uncommon for people to not pass those tests, but we always check. This slide's a few years old. It mentions that more than 10,000 patients have been treated. That's a considerably higher number because it's been 3 years. As much as 4 years ago, focused ultrasound became the dominant way of treating essential tremor when medication didn't work. So it's a past DBS, deep brain stimulation, which we'll talk about in a moment. That has not happened for Parkinson's yet. The indications for use of this in Parkinson's tremor are a bit narrower and more restrictive. We can come back to that as well. But for essential tremor, we're now got much bigger numbers than this, and it is the #1 choice of most patients as a way to treat their tremor when the medication's not doing the job. And again, it's been out there in all the top medical journals, many reports, randomized clinical trials, all of that good stuff showing how well this works. So what are the actual numbers? What does this actually mean in terms of people who are considering this? Here's the bottom line you see on this slide. 73% tremor improvement at 5-year follow-up. Yeah, I think it's probably a little bit better than that. But what does this mean? What this means is when you come back to talk to people 5 years after their treatment, 5 years after their treatment, they will still tell you 5 years later that, yes, my quality of life is still improved by that procedure that I did, and I'm happy I did it. So why is it not 100%? The main reason for not being 100% is that in many people, tremor is progressive. It gets worse over time. We intentionally, even with this new and safer method, we never want to make this hole too big. That's a delicate, important area of the brain where we're making this little pea-sized hole. You don't want that to be too big because it can affect voice and balance and other things. So you're restricted by safety to what you can do. And some people will have some return of tremor. Now, you can always make this hole bigger, but you can't take it back and make it smaller again. So that's the main reason that people will say, one out of three, 1 out of 4 people will say, well, I did it, but at this point, I don't think it really has helped me very much. The other reason for this is patient-reported satisfaction. This is not what the doctors would say in evaluating a patient, and it's natural human nature to report what's still wrong. So in many people, if you show them videos of what they were like before, they'll say, yes, I'm better. I recognize that my tremor is much less, but it's not gone to the point where I think it's made a big difference in my quality of life. So there are people who don't have a complete response. This is a flexible number, and it's one that's changing over time. I think the main lesson here is that nothing is 100%. This is surgery. Even though it's non-invasive and no cuts in the skin and no drill holes and so on, it is still surgery. And there are limitations to what you can do to remain within safety bounds. And there's always going to be some degree of incomplete response, or people who say that, well, it didn't do as much as I had hoped it would. There are some side effects that people can get. In addition, some of those are listed here. The main one that I worry about the most is balance or walking problems. These generally are all gone in the first couple of weeks, but I treat all my patients with steroids after we do the focused ultrasound. Steroids are a way of suppressing inflammation, and I put people on that for about a week. I have everybody come back to see me in clinic the day after the treatment, because those sound waves are burning a little hole in there. And if you've ever had a burn injury, burned your finger, you know that it's the next day that it swells up. So I want to have people come back, make sure the day after the treatment that they're doing okay, adjust their steroid medication if needed, and I'll often get a follow-up MRI scan just to make sure everything looks okay. Very rare for people to have long-term issues with anything neurological or function. The most common one that's reported as this one down here, paresthesias, which means tingling in the palm of the hand. I have not seen that one actually myself. That is something that could happen if your little hole is a little bit too far towards the back of the head. It's not something that interferes with function. Most people tolerate that pretty well, but it is rare, and it is, this is usual. This is the fine print on the label, which you're going to get with any medication or any surgery. But it is important to understand these things and to ask your surgeon, whoever's doing this, to ask about, what are the likelihood of these things? What are we going to do if these things happen? This is part of weighing whether you want to do an operation in a situation where we're aiming to improve quality of life. So all things to know about and take into consideration when we're doing this. So again, a little bit more about what happens during the day of treatment. We've shown some of this already. This is a little video, which I'll play for you now.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects. During the
and fine print here, you have to be shaved completely bald for this. You have to be like a bowling ball, because the sound waves will not go through hair. The hair, no matter how closely you shave the hair, if there's any stubble there at all, you'll have little air bubbles with it, and the sound waves bounce off air bubbles. So for my older generation patients, I tell them you're going to look like Yul Brynner or Telly Savalas. From my younger patients, people under the age of 40 or so, I get a a puzzled look as to who they're. So I just tell them, you're going to look like The Rock or Sinead O'Connor or something like that. But yeah, you have to be shaved completely bald for this. Some people actually like the look and keep it. And the other good news is I have one of those Balder Pro things with the multiple razor blades on them, and you get to keep it at the end. So you take it home with you. Uh, the rest of it is kind of what we've talked about already, the testing during the procedure, going in and out, making sure we're getting a good effect, checking with the patient to make sure they're not having any side effects or any discomfort before we make this a permanent spot. So, again, reiterating what we've said a few times here, this works immediately. When you leave the hospital, the tremor's under control. There's no programming necessary, no follow-up visits to adjust anything. I do follow up the next day to make sure people are okay, but the effect on the tremor is right away. Go home the same day. I also mentioned I modified that a little bit. I like to have people stick around and see me in clinic the next day to make sure everything's okay. Obviously, I can't get people up to walk around the room when they're having this treatment, so I do want to make sure that, especially when that little bit of swelling occurs over the first 24 hours, I want to make sure people are safe walking around, that their balance is okay. So I'm a little bit more conservative about this in checking on people's function the next day. But sure, some of these things are obvious. We're not making incisions in the skin or drill holes, so there's no risk of infection, bleeding. There's no hardware that's put in with this. No anesthesia is involved. And this is, again, you'll see the hat instead of the hair. The bandages there are excessively large. That's where there is that hat that fits on the head with little pins that leave things like mosquito bites. We put on those little round dot band-aids, and they give us ones with like cute little koalas and things on them. I don't put giant patches like that on people. And people sometimes don't even notice that those things are there. They look like mosquito bites and they're gone by the next day. People will ask about what is the insurance coverage situation for this. Medicare covers this. Most of the blue plans, most insurers do cover this. There are some exceptions. I believe United is one that does not. So, again, since this is an elective thing, if you happen to have one of those few that don't, you can consider changing your coverage in the enrollment period that comes around. Again, one of the helpful things here is that these are long-term problems. This is never done as an emergency treatment. So if there is a problem with insurance, one of the things we've helped patients with is either appealing that decision or encouraging them to change insurers to somebody that does cover it. Okay, so I mentioned earlier on that in the days when we burned holes in the brain, we could only do one side because people had problems talking if we did both. That's no longer the case. We learned when we were doing this with radiation treatments that you could do both sides if you waited a while. If you let the body adapt to the treatment on the first side and came back a year later, you could do the second side and not get these issues with speaking or other side effects. And Insightec looked into this early on and was able to show that you could do the same thing with the focused ultrasound, that if you stage the procedure, you can do the second side. The way this was set up to prove safety with the FDA requires us to wait at least 9 months after the first procedure before going on to do the second side. And again, this is not for Parkinson's. This is only approved now for essential tremor to do both sides. I mentioned before also, I give people that clipper, the Balder Pro, to go home with so they can bring it back when they want the second side done. I'd say the majority of people with essential tremor do want the second side done at some point, unless their tremor is mostly one side and not the other. Right-handed people, even if the tremor is solved on the right hand, will find that when they pick up a tray or a newspaper or a book, the tremor on the left hand is still a problem. They can't really go down on the medication without making the other side worse. So the majority of people will eventually want the other side done. It's not a requirement, but it is approved. It's just that we're required at this point to wait about 9 months. The outcomes are actually slightly better on the second side. And when you think about it, that makes sense. it's people who are very happy with their first side who are going to come back. So you'd expect that the second side, those numbers in satisfaction are going to be a little bit higher. The temporary side effects are the sort of things that I had mentioned, numbness and tingling, difficulty talking, balance and walking issues. These tend to be very short-lived. I treat these with steroids. These are due to swelling, and these are mostly gone in weeks when they happen. But again, there's no requirement for people to have both sides done. But there are limitations to having only one side, and it's a subjective decision that we make together with our patients. Okay, so for focused ultrasound, just kind of wrapping up the discussion of this, and then we'll go on to talk just a little bit about what the alternatives are. This is a proven non-invasive method. The approach of making little holes to interrupt that malfunctioning circuit, that concept has been around for many decades. This is a newer technology that's designed to do this in a non-invasive manner that does not involve cuts in the skin, drill holes, anesthesia, or open surgery. But it is still surgery. It is still brain surgery, even if it doesn't involve a drill hole. No surgeries without risks or side effects. Benefits and risks need to be carefully considered. This is a discussion between a patient, their family, sometimes the neurologist, and the surgeon about, should we do this? When do we do it? You know, is this something that we can take care of just with medication, or has it risen to a level where it's worth going through with this, knowing what's involved and that there are possible side effects in order for the high probability of getting that tremor under control? All right, so when people are concerned about focused ultrasound and the concept of making a little hole in the brain permanently is not appealing, we have deep brain stimulation. Many of you will have heard of this. I mentioned that the idea of focused ultrasound is based on these decades-old observations that you could make little holes to interrupt those circuits in the brain that were causing the tremor. I also mentioned at the beginning that in those days when we put a wire in there to cauterize that spot in the brain, we put the wire into the burr hole, before we heated it up, we would run a little bit of electrical current through that wire to see if it stopped the tremor. That told us we were in the right place. Well, in the early 1990s, a fellow named Alim Benabid in Grenoble in France got the idea of using some existing technology, some off-the-shelf stuff from a company called Medtronic that had been originally developed for other applications. And his thought was, well, if we're using electrical stimulation to check on the safety, what about if we just don't burn a hole and continue to electrically stimulate? What if we put in the stimulator, build it in like a pacemaker, and just keep the wire in there and run the stimulation continuously? And that works, and that is the basis of DBS. The target is the same for tremor as it is for what I just told you about, for tremor-dominant Parkinson's and for essential tremor. We put that wire in the same place where we'd otherwise be aiming the focused ultrasound. For DBS, there are other targets in the brain that we use mostly in people with Parkinson's disease. Now, some of these targets are approved for focused ultrasound as well, but they're not commonly used for a number of reasons with focused ultrasound. One of those is that you can only do one side. With DBS, you can do both sides. You can put both wires in both sides of the brain the same day. And basically what you're doing here, instead of making a physical hole in the brain, you are using that electrical current to jam the signal. So you're just blocking it with electrical current rather than a physical cut. And just a brief summary of what I've already mentioned, the hardware was developed for other things, originally used for chronic pain. Didn't work so well for that, but the technology was all there. And so Alim Benabid just used the device that already existed, used it off-label, and had great success with this. And there was a period between 1997 and 2016 where the hole-making business went away. We were no longer putting those wires in to burn holes in the brain. We did not yet have focused ultrasound. And so DBS was kind of all we had for that period of nearly 20 years. What are the advantages of this? Well, once again, this is something we do when medication doesn't work. You have a little bit more flexibility with this to use it for other symptoms of Parkinson's. I had mentioned earlier that tremor is not the only symptom that happens with Parkinson's. This has a little bit more flexibility to be used when tremor is not the main symptom. So we can use it for people with Parkinson's where the main problem is stiffness or slowness or side effects of medication. And the main thing to know about this is, I've mentioned a few times that with focused ultrasound, you make that little hole, you can't undo it, which is why we're very safety conscious, why we have our patients awake talking to us while we do this, because once you make that hole, you cannot take it back. With DBS, it is still an invasive procedure. It's minimally invasive. We're putting a wire in that's about the size of a piece of vermicelli, but you're not making a hole in the brain. The electrical stimulation can be turned on and off and can be adjusted. So there are some advantages to this. You can also do both sides at the same time, so it has that advantage. However, the fact that it's adjustable means, of course, that somebody has to do the adjusting. So this does involve several stages to get it in. We do the surgery in two parts, one with putting the wires in the head and the second on a different day to put in the pacemaker part. These are permanently implanted pacemakers and wires. There's a battery that needs to either be replaced or recharged, depending on your system. And it does require programming. So it's not a set it and forget it sort of situation. Again, DBS for tremor works in a very similar fashion to what we've already talked about. There are a few other types of tremor that this can be used for with less impressive results. So does this work better than focused ultrasound? Not really. You would see here for tremor, you remember we showed that 73% at 5 years. Well, here it's 75%. So the outcomes, the satisfaction is similar to what we see with focused ultrasound. It's different. They have similar effects. They're just different. And the reasons for the 25% not being there are also somewhat different. We get obviously more complaints about the visits and the hardware and this thing under my skin, it bothers me, and so this sort of thing. So the reason a patient will say they're not totally satisfied is a bit different with focused ultrasound, but it's about the same number. So it's not like one of these is dramatically better than the others. It's a trade-off. Each one has advantages and disadvantages. So some of the advantages, it's selective. There are a few more targets in the brain you can use. It's minimally invasive. It doesn't involve making holes there. It's adjustable and programmable. There are some new things coming along. Some of you may have heard Medtronic just got approval for the use of this technology in Parkinson's, not in essential tremor, but in Parkinson's, where the device can adjust itself to some degree, saves some trips to the neurologist for making changes in the output. So that's something that's new, but again, that's for Parkinson's. It does not apply to essential tremor. So there are improvements in the technology. Most of the computer sensing and the business end of this thing is a wire in the brain, but it's run by a thing like a pacemaker under the skin of the chest. And those pacemakers can be replaced, upgraded, and so on. Disadvantages is that this is invasive. It does involve surgery. It involves 2 drill holes, putting wires into the brain to that target. It can be done either awake or asleep, depending on the situation. It is possible to do this with people completely asleep. One of the considerations in thinking about this type of surgery in someone who really doesn't like the idea of having anything done with them awake is that you can do DBS completely under anesthesia. You can't do that with focused ultrasound because we need to be able to test you as you're having this done. Hardware problems, hardware can become infected. In people who are thin, you can occasionally have hardware wear through the skin, become infected. The battery needs to be either changed or recharged. And when the hardware is in, there's certain limitations on MRI scans and so forth. And some people just don't like the way it looks, even though the hardware is all under the skin and it's small. There are people who are kind of aware and self-conscious that they have these things. So these are some of the advantages and disadvantages of this other approach. Both of those things are available through MGB. We have 2 centers. Some of you have heard that we've kind of merged with the Brigham. They have a program for all of these things at the Brigham. We have a program at MGH. We work in very similar fashion. I've mentioned before, and I'll say again, that we work as a team, surgeons, neurologists, neuropsychologists. I think that it's important for people to know all of their options when they come to making a decision about surgery. We don't push people towards one thing or the other. We present those options, but we also want to get a thorough evaluation of our patients to try to match up the diagnosis with the best therapy to make sure that we're getting our optimum chance of a good outcome that's going to make a patient happy and improve quality of life. So with that, I'm going to wrap up the talk here. If you want to take a picture of our QR code here or jot down the number, Paula is my assistant, our program coordinator. This is information on contacting her. And again, I'm delighted to take questions now for the next few minutes, but you feel free to contact me anytime through these numbers if you'd like to learn more about our program. And with that, Alex, I'm going to turn it back to you. Thank you, everybody.
Perfect. Yeah.